and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to go through an article, as I have been doing, from the Journal of Osteopathic Medicine. So this is from America, not the International Journal. The paper that I'm going to look at, please excuse me as I cough, one moment. Okay. So the point of what I'm going to do is to show an experiment and an experimental design that I think is defensible and for the most part solid. But there is one thing in the method that, to me as an observer, is unfortunately fatal to my ability to have confidence in the claims. It doesn't mean that the claims are wrong. It just means my ability to have confidence in them hinge upon one piece of the methodology. So the paper, the name of the paper is Revisiting Chronic Low Back Pain, Evidence that it is not non-specific. Clarence L. Nicodemus, Alan Sikorsky, and Jessica Epstein. Yeah, I don't know if it's Steen or Stein. Please excuse me as I cough again. I don't have a mute button close. If I did, I'd use it, but I don't have it. So anyways, this was published in November of 2022. It's volume 123, issue 3. So I think that's in 2023. I don't know. Anyways, so I'm going to read through this at a reasonable level of granularity, just so you get the good stuff, and then I identify the one thing that gives me trouble here. So to read from the introduction, chronic low back pain, CLBP, is commonly referred to as nonspecific. However, this paper proposes a novel perspective that CLBP has a single specific cause. It has been observed that several pain generators are commonly associated with CLBP. We hypothesize that joint dysfunction or restriction, specifically the sacroiliac joint, is a major factor in lumbosacropelvic LSP control system changes that lead to CLBP. So I'm just going to stop here for a moment. You have to buy what they're selling to move any further. I'm not against what they're suggesting because it is a hypothesis worth exploring. You have to buy certain things about specifically the sacroiliac joint, that it moves in the way that it is assumed to move by some anyways, and that the lack of movement is a generator of pain. You have to believe certain things about pain as a marker. Pain is a challenging clinical marker because it is not directly observable. It must be reported by the patient. The patient is almost always going to report in good faith because it does not benefit them to report dishonestly unless they sometimes feel like they're not getting attention, because then it is at least possible to magnify a report of discomfort or pain if you feel like you're not being paid attention to. So there's a lot of things going on. Pain is not my favorite marker. It is a marker. People definitely place value on it. It's not my favorite. It does matter. To read again, we hypothesize that joint dysfunction or restriction, specifically the sacroiliac joint, SIJ. Yeah, I already read that. Way to go, buddy. The SIJ, so to read slightly later on, the SIJ is the synovial joint that connects the spine's sacrum to ilium, which is the upper portion of the innominate or hip bone. Numerous strong ligaments support and maintain SIJ function, which transmits dynamic force through the pelvis from the hip joint to the lumbar spine. Additional elements can become painful in the surrounding ligamentous and muscle structures. Our pilot data into the clinical presentation reveal a correlation between the presence of SIJ restriction and many of these pain generators. We conclude that the SIJ plays a major role in CNS control of the system around that joint, as observed in the arthrogenic muscle inhibition phenomena that's cited properly. We hypothesize that a correlation exists between the presence of an SIJ restriction and many of these pain generators, and we suggest a specific factor contributing to CLBP, chronic low back pain. The thing that catches me because of my preferences with all of that is numerous strong ligaments support and maintain SIJ function, which transmits dynamic force through the pelvis from the hip joint to the lumbar spine. So my preference with The region is to identify that the things that are going to put meaningful force through the sacrum itself are things that move quite a bit, which are the hip and the lumbar column as the closest relative structure, such that it is more likely that those things will lead to what would be diagnosed as SI joint dysfunction, versus the SI joint leading to dysfunction of the low back or the hip. So I tend to prefer looking at the bigger things and ensuring that they're doing what they ideally should do, as opposed to looking at the sacrum as the central portion. So just because something's in between things doesn't mean it's the driver. It could just mean that it's in between things. Sometimes it is the driver. How do you find out? Well, you test everything, and whatever is most messed up, that's what you work on. Anyways, that's a tangent from personal preference, not correct preference. It is aggregated across a lot of clinical experience and understanding the evidence that I've encountered with respect to the sacrum itself. So that doesn't mean I'm right. It just means that it's the aggregation and approach that I take. To read again, this perspective is consistent with the osteopathic medicine principle of homeostasis, that is, incorporating a feedback control system that senses and regulates the neuromusculoskeletal system, NMSK. It is proposed that CLBP is a syndrome and is most likely the result of perturbations within the NMSK control system in the LSP, lumbosacropelvis region. Yeah, as a hypothesis, I get the concept of the control and the region. I don't know that I would generate this hypothesis in this format. It's somewhat removed from the foundational groundwork that you would need to do. It's a few layers up. So they're identifying the assumptions. The assumption is that the NMSK, the control system, is the thing that drives this. So you could argue from reading that it's interpretable as it's mostly neurological dysfunction that ends up so from sensory and from motor, that ends up generating this. It's a perspective, right? I'm not against it. I think it's reasonable as a hypothesis. I just don't know that I would see a lot of people getting to the specific aggregation of approaches and assumptions, and that's fine. It is proposed. CLBP is the second most common cause of disability in U.S. adults and the most common reason for lost work days. A population-based study in North Carolina from 1992 to 2006 reported the prevalence has increased from 3.9 to 10.2% over the past several decades, and that focus should be placed on causality and self-management to address this issue. The 3.9 to 10.2%, that's a pretty big increase from 92 to 2006. There could be a lot of reasons for that. It could be more reporting. It could be a change in culture where people feel like calling off work and providing a reason, and the reason is back pain. It could be changes in behavior, whatever behavior that might be. There could be a lot of reasons for that. That's a pretty big jump. Right. To read again, the confounding issue may be the misunderstanding of what is causing CLBP. The current general perspective of nonspecific CLBP is that it is multifactorial, multifaceted, and relates to a disorder of the lumbar spine. A 2018 paper stated low back pain is usually nonspecific or mechanical. Mechanical low back pain arises intrinsically from the spine into vertebral discs or surrounding soft tissues. One of the reasons that it is more parsimonious to take the position that it is non-specific is that because when you check things with certain forms of diagnostics, you don't find what you would be expecting as the driver of the low back pain. So you would then call it non-specific. So when you check it mechanically, depending on the test that you use, it quote unquote passes the test. It could be that the issue is the tests that are being used to check for these things. It could be something else. You'd have to dig into it to figure that out. But the most parsimonious explanation, when you use specific tests, you don't find dysfunction, and the person reports pain, is that it's non-specific. I can't find the physical cause for it with the tests that I've used, therefore it's non-specific. That is generally supported by currently updating views on pain. So pain being multifactorial, multifaceted, dependent on the individual, previous experience, things of that nature. Interoception is a thing, but the what happens from the interoception or from the nociception or the nociceptive sensation, and at the interpretive level, cognitively, has a lot of variability. So because it's confusing and the tests that have been used are not finding things, then maybe you call it non-specific low back pain. The problem could be the investigative method or the tests that are used within the investigations. So I see that as a reasonable, parsimonious explanation. However, I'm not sure that the ground level work is being done in a way that everybody would agree with. So fair enough. To read again, alternatively, others state that 85% of CLBP cases do not come from a spinal disc or nerve injury disorder, but rather from a wide variety of musculoskeletal MSK issues, thus non-specific low back pain. A 2015 study of 320 patients at walk-in orthopedic clinics in Japan reports that they identified the cause of CLBP in 79% of cases by conducting extensive examinations by orthopedic specialists. Unfortunately, the researchers hypothesized that the causes of CLBP based on clinical examination without treatment confirmation. So they didn't test their findings, so they didn't apply treatment to what they thought their finding was to see if it improved, because the fundamental hypothesis should be that I find problem here, I treat and change problem here, and then report of back pain should change. So saying they didn't do that. Many new lines of scientific and clinical investigation are being undertaken to study low back pain, but have not yet translated into practical solutions, particularly for people with CLBP. Yeah. A veteran's, so I'll continue to read. The moaning and groaning was just, should I read this? A Veterans Administration VA research paper published in 2020 proposed that CLBP is a syndrome rather than a non-specific pain condition. That is, CLBP is a common pathway for a combination of contributing factors, including spinal degeneration, the common presence of pain generators such as SIJ syndrome, leg length discrepancy, iliotibial tendon band, ITB syndrome, and greater trochanteric pain syndrome with back pain support this theory. No central mechanism or cause was proposed. The model proposes a similar concept that CLBP is a syndrome, a commonly occurring group of symptoms with a common cause. So if you're attempting to generate diagnostic approaches and standards, and you're going to talk about a syndrome, so you're suggesting that the construct of chronic low back pain can be generated by multiple things. So it is a stable report with unstable signatures, similar to the theory of constructed emotion, and similar to almost all reported physical sensations or categories of condition with physical sensation. To read again, as with most physiological systems in the body, whether regulation of blood pressure or heart rate, an MSK system is also a control system. The concept, okay, they should have cited that better. The concept of a control system is feedback loop, so you get sensory information and it will alter motor output, or you'll provide motor output and the sensory information will adjust. That's fair, but if I was the editor, I'd want that cited properly. That's personal. To read again, the concept of joint dysfunctioning affecting the muscle as a part of an MSK control system is well studied in the peripheral joints. We propose that this also applies to the LSP region. When a peripheral joint is dysfunctional, surrounding muscles and tissues are inhibited or facilitated in a sensory feedback loop. Inhibited muscles are affected at the synaptic level of afferent nerves in a phenomenon called AMI. That is cited there, at least. What I'm going to do a little bit with the methods, with the data source, and then the actual measures. The measures are where I end up in having confidence issues. So everything so far, I find it defensible. I don't find it fantastic, but I find it defensible. If it's defensible, we continue to consider and move with it. But if it's just falling on its face, well, you throw it out before you get to this point. But so far, it's defensible. I'm okay with it, even if I have some qualms. The data source. Following institutional review board approval, they noted MSU IRB 17-675, a retrospective chart review was conducted in 2018 by the author CN of new patients during a randomly selected year and start month, June 2013, in 8 years of private practice. The author CN is board certified by the American Osteopathic Board of Neuromusculoskeletal Medicine, AOB, and MM. So you need ethics approval. if you're going to basically be dealing with anything that, like any kind of genetic material, anything living, and often privacy concerns. So there will be times when you don't necessarily require IRB approval for chart review. Sometimes, as long as it's anonymized and whatnot. But when you're going to review and it's not anonymized, then you would need the review ethics approval or the ethical approval. Let's go back to reading. The year and month were randomly selected by using a random date generator for the interval between January 1st, 2008 and December 31st, 2016. The reason you want to randomize it is because you don't want to be picking the ones that look the juiciest. You want to grab anything and see what the signal is, because essentially you would make the assumption that you're going to get towards the central phenomenon as opposed to the outlier, right? So the outliers would be included at the same level of probability as the ones in the middle of the pattern, right? So defensible, totally fine. The review charts were the records embedded for patients in the practice's electronic medical records, EMR software, Mac Practice Incorporated, Lincoln, Nebraska. The clinic was operated as a solo practice with a single provider. The patient inclusion criteria included new patients who were treated at the clinic during the selected year, 2013, and met the inclusion-exclusion criteria. Inclusion criteria were patients 18 years and older who were ambulatory, aka they could walk, and who could understand and follow instructions. The exclusion criteria were patients with spinal or neurological disorders, spinal fractures within the past year, or severe osteoporosis, scoliosis, or osteoarthritis in the spine or hip joints that would be previously diagnosed or diagnosed through the process. The reason that you would exclude the people with known vertebral pathology is because that is a more parsimonious explanation of low back pain. You're looking for people who don't have those factors as contributing. To read again, the patients must not have a history of diagnosis of retroperitoneal tumors or lymphadenopathy, or a diagnosis of lumbar spine radiculopathy verified by imaging, electromyography, and nerve conduction velocity testing, as well as matching symptoms. A patient with a spinal surgery completed within the past year was also rejected. Rhizotomies, epidural injections, spinal cord stimulator implants were acceptable if completed at least 3 months prior to the beginning of the study. The reason that you'd set that cutoff is because there could be acceptable, understandable pain because you got cut. You got cut open for those things. To qualify for the diagnosis of CLBP, the patient must have been diagnosed with nonspecific chronic low back pain, which consists of having not been excluded by the above criteria, having symptoms of CLBP for more than 3 months, and being within the ages of 18 and 95. Other than notations concerning the pain-generating tissues associated with CLBP discussed below, only anonymous demographic information, sex, age, and insurance type was extracted. So again, just being very clear on how they generated the data. So this wasn't an experiment as such. This was a retrospective chart review, which is quite accessible, but you've got to do it the right way. And again, very defensible. So this is where we start to get into the part that I have an issue with: measures, methodology. The data recorded included the presence or absence of SIJ restriction and tenderness in 7 bilateral structures within the LSP region known to be the principal pain generators most closely associated with CLBP. The iliolumbar ligament, the psoas muscle, long dorsal ligament, sacrotuberous ligament, piriformis muscle, iliotibial tendon band, or the IT band, and adductor magnus muscle, hip adductor magnus muscle. Hip adductor magnus muscle, HAM. SIJ restriction. Okay, so all of that sounds good. Those are structures that, based on the research and you trusting how the research was done prior to you utilizing these as the sites to assess pain generation. And also you have to believe that the presence of tenderness in these areas and the presence of low back pain are related in something other than time and being in the same person. So the coincidental or coincidence of timing and location, or being within the same person, such that it's actually causative or properly related to the low back pain as you think it is. That's not an unreasonable assumption, because if you see it across enough people, well, it happens so consistently that the coincidence of timing and presence inside the same person seems to be properly related. So you can get past doubt appropriately, but you have to buy that you can also palpate these structures properly, and not just because you're touching in the area. So if you touch in the area of the iliolumbar ligament, so basically between PSIS and this, the laminar groove around L4, L5, really more L5. First of all, you got to actually be able to palpate it. They can't have too much subcutaneous fat, which most people do, regardless of how lean they are in that region. That the pain generated is from the ligament and not another tissue that is superficial to it, because there's quite a few of them. The location of the tenderness also, 2-point discrimination there isn't fantastic. So I would have a challenge buying that with confidence. I can say the pain is generated by the iliolumbar ligament and not just coincident with the region. The psoas muscle, I'm just not buying the palpation of it. There is an MRI study out there that I've seen some attention go to with one person with a high BMI and one person with a low BMI, and you get within 4 millimeters of the psoas in the lean person, and I think it's 6 millimeters within the higher BMI person, and that generally the organs move out of the way as a unit because they're all in a bag. But that doesn't mean that you're palpating the psoas or that you're eliciting tenderness in the psoas, because there is so many structures and so much sensation that could occur coincidental to the region that you're just interpreting it and naming it psoas instead of naming it ouchie where I pokey, right? Because it's just this is really more ouchie where you pokey and not as indicative that it's the structure. You're just making the leap that because the structure is close there, I'm going to name it that, and that's what the heck is going on. The long dorsal ligament, yeah, give me a break. Sacrotuberous ligament, you can get closer to it, but there's fat and butt tissue, right? Like you've got the glute max covering some things. Sure, it's mildly exposed, but your ability to be certain on that, questionable. Now, if this was ultrasound guided, maybe I'll take something different. The IT band, IT band's not hard to find, right? That's pretty obvious. The adductor magnus, reasonable to find, but it's still kind of ouchy where I pokey. Now, this is where, you lose me, whether it matters to you or not. I'll tell you anyways. SIJ restriction was determined by utilizing 3 techniques: standing and seated flexion tests and pelvic rocking. Okay. Those are standard, but they're dumb. If you're going to tell me that a standing flexion test is going to tell you something about the sacrum, then I dare you to not find a pre-existing vertebral column asymmetry in dynamic movement that would unevenly pull one side of the pelvis versus the other. If you're going to tell me a seated flexion test that also, no, right? There's so much other stuff happening, and the movement is generated by moving the vertebral column. So you're assuming things based on what you consider dissociation of structure. No, this is not honest. It's standard, but it's not honest. And the pelvic rocking, absolutely not. No, there's going to be uneven pressure. You're going to be standing on one side, even if you test it on both sides. You're not accounting for the squishing of the patient's soft tissue into the table. You're not accounting for uneven movement in the practitioner. You're not accounting for the movement of the padding or the foam on the table. No. No, I don't buy this as a way to identify SI joint restriction as a claim. I do buy it if you do the same test all the time and you notice inconsistencies. You can then tell me you're naming it SI joint restriction. I won't buy that it's accurately testing SI joint restriction, but I will buy your consistency. So the intra-rater reliability is probably fine, but the claim that it's the SI joint is not fine. It is not okay. This is a problem, right? The rest of it, I'm a little bit more on board with. Ouchie where I pokey, sure. Right. To read again, once SI joint dysfunction was confirmed, the presence of each pain generator was determined by direct palpation of each of the LSP region structures with patient response. Okay, so they're asking, is it ouchie where I pokey, as the things that they named as the assumption of what they're poking. Right. The presence or absence of pain was recorded as a 0 for no pain and 1 for any pain. It's binary. It's either present or absent. It is not intensity. This is defended after here. Muscle palpation was done at the approximate middle of the muscle belly. That's a choice. Why they made it, I don't know. If you ask, they could defend it. For ligaments and ITB, tenderness anywhere along its length was considered positive. A pain scale was not utilized because a longitudinal study of outcomes to treatment was not an objective of the study, so relative change was not considered. The presence or absence of pain, as verbalized by the patient in response to direct palpation by the provider, was the only criterion utilized and recorded at the patient initial visit. Okay. So there are results from this that have value, because there is consistency. There is proper intra-rater reliability, or the same rater doing the same thing. Therefore, you can trust that the phenomenon that were identified are the phenomena that were identified. However, you can't necessarily trust in a proper way that it is the structure as claimed. The one, as I already noted, is the standard testing approach to what is considered the SI joint movement and dysfunction, and I don't buy it in the slightest. I buy that if the tester, if the rater did the same thing consistently, that the phenomenon is correct, but I don't buy in any way that it's the SI joint. I'm willing to be challenged on that, but the SI joint, the ability to move it, first of all, it moves exceptionally little, in almost everybody without trauma or pathology, or being a child, right? And also when you're a child, you don't actually have a sacrum. You have sacral vertebrae, and they fuse across time, and in probably a variable time frame. So yeah, the results, I'm going to go do the results from the abstract here. So the associations between SI joint dysfunction and each pain generator were statistically significant. Phi coefficients indicated moderate strengths of those bivariate association. Iliolumbar ligament and psoas muscle were significant predictors of SI joint dysfunction in the multivariable model. I poke you basically between your PSIS and your vertebral column, and you say ouchie there, and you have chronic low back pain. That doesn't seem surprising. I poke you probably medial to your ASIS, and I call that your psoas, and you have pain in your low back regularly. This isn't a surprise. To me, it fits my model of general hip dysfunction and general vertebral column dysfunction as being related to low back pain, right? So it fits my model well, the finding. It doesn't necessarily describe the model that I prefer well. It doesn't mean I'm right, and it doesn't mean they're wrong. It just means that I have some disagreements that I would have to do some cleaning of, or some better understanding of the viewpoint here to maybe come closer to this position. I can't say that this position is wrong, but I can say that I have methodological challenges. So, ouchie where I pokey, I buy it, right? Especially if you're consistent. If you could be consistent between raters, I buy it more. Somebody feels ouchy when I poke between their PSIS and their SPs, yeah, I believe they're going to have low back pain chronically. If their hip is funky in any way, so like I would have liked to have seen some testing of hip rotators, or just broadly, if there was pain in the hip rotator, did the person have chronic low back pain? But then I would also want a control group of people who did not have chronic low back pain and see how often they had pain upon palpation of hip rotators. Reasonable experiment to run, because you would likely find that there is a rate at which people have tenderness when palpated in hip rotators and not chronic low back pain. And then also you'd find a rate at which people have chronic low back pain and not have tenderness upon palpation of hip rotators, right? So you could determine that. It's not terrible to do. It'd actually probably be pretty quick. So yeah, this isn't necessarily increasing my confidence in the SI joint, but it would increase my confidence if I was paying attention to more clear information about where the psoas was palpated as the ouchie where a pokey point, and the iliolumbar ligament point, which is basically you go between PSIS and the lowest SP you can find, and you poke them there, and they say ouchie or they don't. I buy that more than the SI joint. So there is some valuable stuff here. If you get a little bit more abstract, you pull a little bit further back, you get rid of SI joint dysfunction, and you say, hey, I found these 2 points that are highly coincident with chronic low back pain. When I poke them, they say, ouch. That actually seems like the more important phenomena. Very consistent, quite interesting. So, yeah. I think this is very valuable research. I think with minor adjustments, it might be even more valuable. And I'm glad that it was done. I'm glad that I found it. And hopefully, me reading through this and telling you my challenges with it has done something positive for you. Thank you for listening this far. Hopefully, you've learned something, and we will talk again soon.